Our next presentation features Dr. John Corboy. Dr. Corboy is the medical director at the Rocky Mountain MS Center and director of the Rocky Mountain MS Center at the University of Colorado. Dr. Corboy will present Beyond Disco MS. What did we learn?
Great. Thanks, Michelle. Thanks, everybody. I'm going to go through these, and some of them I'll go through quickly, and others I'll stop and talk a little bit more about. And we'll have questions at the end. And if you have questions, please write them down on an index card, and we'll add them to the other list of questions that we have so far. And these are my disclosures. And I know that over the course of the years, we've stated this a number of times, but I think it's really true, and it's always important to remember that the ultimate goal that we care about is, from a neurological point of view, is lifelong brain and spine health. We take the very long view. Many people are diagnosed when they're young, but we want to look forward and say, what are you going to look like when you're 40, 50, 60, 70 years of age? Because ultimately, we want you to get there, and to get there the best way possible. And this is important. We spend a lot of time in studies focusing on younger patients, but if you look at this slide from the epidemiology in the United States, the reality is that almost half the people in the United States with multiple sclerosis of adults are 55 and older. And the most common epoch, if you look at these 10-year chunks, is actually 55 to 64. So even though there's been a huge emphasis on studying primarily younger patients with relapsing MS, there are many patients who are older. And we'll focus today on disease-modifying therapies, but some of these things that we also talk about in terms of behavioral changes, treating comorbidities, and other things, as noted there, can also change throughout the lifetime of the patient and are relatively more important at different times. Younger patients with relapses and treating with steroids, older patients with comorbidities like diabetes, high blood pressure, arthritic changes, needing a hip replacement. So all of these things can also change throughout the course of the lifetime. But we're going to focus on disease-modifying therapies. If you've been to any of these talks in the last few years, you've seen some variation of this slide. I think I got this one from Dr. Alvarez, I'm not sure. But what it really shows, importantly, is that we have had a remarkable surge since about 10 years ago of new medications, now up to 9 or 10 classes, 20 different medications, biosimilars, generics, off-label use. And we've been incredibly blessed to have this opportunity over the last 30 years to be able to have these available. And here's just a broad breakdown of the different classes. So the important point is that we have many different choices, and they're not all necessarily the same for every single individual. So the determinants of therapy choice for a disease-modifying therapy, a DMT, is going to be focused on a number of different issues. Some of these are related specifically to the patients. Some are related specifically to doctors. In this country, a lot of them are related to insurance issues, whereas in Western Europe, a lot of them are related to national formularies. If you are part of Kaiser, for example, it's whatever their formulary is. So there's a lot of external forces that also go into determinants of therapy choice. And the actual decisions are going to be many, from the time you start to the time you stop using disease-modifying therapies. You know, do I even need to use one? When should I start? What's the best one for me to start with? When should you switch? What happens when you want to get pregnant? How long should you treat? And should you de-escalate or discontinue presently available disease-modifying therapies at some point? And there's more questions too, but these are some of the big ticket ones that we address every day in the office. And in a broad sense, if we think about when we might want to use medication, we surely want to know, is this medication useful? Is the benefit there? Is the efficacy there? And the higher, the better off. And is the risk low enough? We don't want to have super high risk medications with low benefit, and vice versa. We do want to have those with high benefit and low risk. So you can think of high risk, low benefit, probably don't want to go there, and higher benefit, lower risk. This is where we'd probably really rather be. And if you just use these medications as noted here, and sorry, these are all the generic names because I'm a generic kind of guy. We can think the lowest risk medications on the whole are in fact the lowest benefit medications as well. So Aubagio, teriflunomide, the interferons like Avonex, Betaseron, Rebif, Plegridy, and then Copaxone and the generics for Copaxone, glatiramer acetate. And at the other end, high risk but great benefit perhaps the best drug we actually have is alemtuzumab or even stem cell transplants. Nalezimab Tysabri, if your JC virus test is positive, is relatively high risk, as Dr. Schreiner talked about. Relatively low risk if it's negative and stays negative, though. So that's a relative change that could certainly be appropriate. And there's quite a few that are sort of in the middle here. So the reds are places we don't go very much, both low benefit but low risk, or high benefit but high risk. And we focus more down in here. But perhaps the most important thing in making a decision about therapy choices, including whether and when to start, escalate, de-escalate, or discontinue, is where is the patient in time? What phase are they in with their multiple sclerosis? Because this will have a big impact on how decisions are made, in addition to all those other factors. And we can sort of think of the phenotype, that is, what does the patient look like? How are they acting clinically with multiple sclerosis, as on a continuum? So at the very earliest stage, before people even have symptoms, they may have changes on their MRI scan. These are people who have a car accident or maybe migraine. Someone checks an MRI scan and you go, whoa, that looks just like MS. And that's the first visible manifestation of MS. But once you have a clinical syndrome, but may not fulfill all the diagnostic criteria for MS, we call that clinically isolated syndrome, or what we would say in retrospect was the first attack, but didn't necessarily fulfill all the diagnostic criteria for MS. Routine run-of-the-mill relapsing MS, and then progressive forms of MS, either preceded by prior relapses, so people convert from relapsing MS into what we call secondary progressive MS with slow worsening, mostly, but not exclusively, independent of relapses, or those that are not preceded by relapses, people who really start off having slow progression from the outset. Both of the progressive forms of MS typically begin much later than, say, 25 to 30, but more likely in the 40 to 50-year-old age range. And they may or may not have superimposed relapses, and they may or may not have periodic stability as well. So this is sort of the spectrum of what we think about the phenotypes look like. And so who would benefit? Well, there's proven effectiveness in essentially all the relapsing forms of MS, which will soon, I think, and I hope will include even radiologic isolated syndrome. And I'll show you what that really means practically in the next couple of slides. But this would also include individuals with so-called secondary progressive MS if they have recent activity with scan changes or with relapses. That is, those individuals who have what we think of as new activity, either radiographically or clinically, also benefit, even if they also have slow worsening independent of relapses. There's only one medication that's approved for the primary progressive form of MS, and that is ocrelizumab or Ocrevus. And again, noting that in both of these categories here, most of the people studied have been quite young, very young in relapsing forms of MS, and the median age in the Ocrevus study was 44.6. That is very low, and as I mentioned before, half of people almost are 55 and older with MS. And most of the studies that have been done in MS have been completed in people under the age of 55. So the reality is that we have almost no data on people who are 55 and older as to whether or not the medicines are helpful or perhaps harmful. So just looking at the front end of things, we know that even before people have symptoms related to MS, they may have what I told you before with the MRI scan changes, radiologic isolated syndrome, but they may have a number of different things that have been identified in large populations where you could go back and look and say, hey, what was going on before this with people that had radiologic isolated syndrome or before they had first symptoms of MS, and they're all listed here. There are a lot of changes you can see, including changes in brain volume, elevated neurofilament light in serum, as was discussed by Dr. Alvarez. And there are now multiple studies underway, and I forgot to mention one with either Tecfidera, Ocrevus, and there's also one underway with Aubagio, looking at people with radiologic isolated syndrome before they've ever had symptoms to see if they might be useful to treat. And who might you want to treat? Forgetting studies for a moment. The people who are maybe at highest risk of having new clinical activity, even if they haven't had it already. And this is a study from Darren Akuda, who was running the Tecfidera study I just mentioned, and showed in several hundred patients that there are at least three risk factors. If you've never had a clinical symptom of MS, but you have an MRI scan that looks like it, radiologic isolated syndrome, spinal cord involvement, being under the age of 37, and being a male compared to a female, you have a higher risk with any one of those of going on to have clinical syndrome typical of MS in the first 2 to 5 years. If you have all three of those, you can see here within just a couple of years, it's 80 to 90% likely that you will have a clinical syndrome typical of MS. Whereas if you have none of those, you're a woman over 37 with no spinal cord involvement at the same time as you have your brain involved, it's a very low risk over a prolonged period of time. So the risk is not the same for everyone. It's going to be different, even in this very early phase of MS. And this has been shown as well. This is from Christine Lebrun, and this is mostly European data showing pretty much the same thing, although they also looked at contrast-enhancing lesions as opposed to gender, and showed that age, spinal cord lesions, in this case gadolinium-enhancing lesions, each independently had a similar effect. And again, this is only over 2 years. If you had all three of those, a gigantic risk of having a clinical syndrome. So should we treat these patients? Maybe. We'll see what this data shows from the different trials. The Akuta paper is going to be first out of the box, and we'll see what that looks like. The other two are still enrolling, and we'll see what they show. My bias is if someone has classic MRI lesions and they're stable, to leave them alone, assuming that they don't have any clinical syndromes typical of MS. But if they start having changes on their scan, even independent of any clinical activity, my bias would be to treat many of those, especially if they have active lesions on their scan, because as we just showed, that's one of the predictors of having clinical activity over time. And then, of course, for run-of-the-mill clinically isolated syndrome, relapsing MS, or even secondary progressive MS with activity, the standard of care would be just to treat with any combination of the different medications over time and switching as necessary if those are inadequate. So for a big chunk of people between 30 and 40 to 50, the standard of care is clearly to treat on a routine basis with one of the different therapies. And it's going to be based on a lot of different factors, as described in part by Dr. Schreiner, having to do with immunosuppression and risk related to the patients, disability, age, and other things. So we can treat early, but with what? And how we approach treatment will be important to think of over time. And there are three broad approaches to treating, especially early on. You could go with what is often mandated by insurance companies, or in Western Europe by the National Health Services formularies, to start with one of the older medications, or perhaps Aubagio, teriflunomide. And only if you have more problems would you escalate to better drugs, and perhaps to better drugs, or to definitely better drugs, but with higher risk over time if you show new disease activity or don't tolerate some of the medications. So this is called, from an insurance lingo point of view, step therapy, what we refer to as escalation therapy. An alternative, and one that we favor to a greater degree, is to use more highly effective therapy early, and then potentially over time to de-escalate, or use it for a prolonged period of time until you might actually discontinue the therapy. And the logic with this is that your greatest risk, the greatest time you need the more highly effective therapies, is when you are newly diagnosed, and you respond better to the medications when you are newly diagnosed. And I'll show you some data in a couple minutes that you can see that distinction between the better drugs and the less efficacious drugs diminishes as people are started on drugs at an older age. And then finally, you could take sort of the chemotherapy approach, almost like the cancer approach, to use very highly effective but relatively risky approaches very much up front to really try and squish whatever the immune system abnormality is with MS, with the hope that you would then, perhaps reboot your immune system and sort of cut off the MS attack at the knees. And then the logic would be that you would potentially de-escalate to some ongoing therapy for maintenance and or to discontinue over time. Now, this has generally not been used in this country or anywhere else because there are a significant minority of individuals who probably never would need anything like this. And this would be somewhat grossly overtreating a substantial number of people if everybody did that, and the risks are relatively quite high with some of those medications and approaches. But here's the logic that I described for why we use aggressive therapy at the outset for many, but not all individuals. And I won't go through all of this because I mentioned a moment ago. And we run sort of the risk of maybe over-treating some people, but so long as we can do it relatively safely, that is reasonable. If you do it relatively unsafely, that's probably not reasonable. But the biggest thing is that we're matching the potential benefit, because the risk is so high of the disease, with the benefit of the medication, and using the better medication when the risk of the disease is highest makes the most sense. And then as things change over time, perhaps that calculus changes. So who gets the greatest benefit? Numerous studies show, from subgroup analysis of phase 3 trials, from meta-analyses, from a number of different types of studies, that younger people with active relapses, scan changes, active lesions on the scan are the ones that benefit to the greatest degree with the presently available disease-modifying therapies. And this is actually data that Dr. Alvarez and Dr. Bulmer's daughter were responsible for. This published last year in Frontiers in Neurology. And if you think that we know that the natural history of multiple sclerosis is that there are decreased relapses and new scan changes over time. And what on the left here shows is essentially probability of new disease activity essentially follows this pattern when you're talking about relapses and scan changes, with diminishment over time. And that's the annual risk per year of having a relapse or a scan change. And the dotted lines are the 95% confidence intervals, sort of the variation, the error essentially that you would potentially have in that measurement. But the dark line tells us what sort of happens over time. In this study, which is from about, I think it's about 1,200 patients in our own group, we can see that if you start a medication when you're very young compared to starting a medication when you're very old, things are not the same. When you start very young, the better medications, the infusible medications in blue here, have a more profound impact on slowing new disease activity compared to the certainly okay medications, in this case Tecfidera and Gilenya, where there's a higher risk of new disease activity. But if you start in an older age population, the distinction between the IV drugs and the oral drugs is substantially reduced. And by about age 53 or 55, these error bars cross. That is, you can no longer show that there's a greater benefit with the more highly effective therapies. So in fact, you may not be getting much more in the way of benefit, but you may be attaining more risk associated with those medications. So that's an important part to think about. What is the benefit, and when is that benefit seen the most? When is it needed the most? And then what happens to risk over time? So with escalation therapy, you start low and then only escalate as needed. You may well miss the main thing, the main time that patients need the medicines that we presently have available, their greatest benefit when people are young. And then you may be escalating to more perhaps risky medications as their risk actually goes down. And this is backwards. So this is what we have generally been doing for the last 15 years or so. And then the question is, if you start with high efficacy therapy, does this risk change over time? It may well. And should you de-escalate, as you would see, for example, here on the right, would you potentially de-escalate the risk, especially in this age group here at the far end? Or would you go with this induction maintenance approach where you get the highest benefit, but with the greatest risk when people are young, and then maybe you can go to no maintenance therapy and discontinuation early if patients are stable? And so, again, we don't do this very much. We're just starting to study de-escalation as a concept, and de-escalation can have many different ways you look at that. It can have a lowering of a dose. It can have, for example, with our infusible medicines, Tysabri going from 4 to every 6 weeks. With Ocrevus and rituximab, could be from 6 to even 12-month intervals or longer. And there'll be data from Sweden, which has been a big user of rituximab for the last 15 years, soon looking at extending that dosing out. So there are ways to potentially reduce risk over time, but still maintain benefit in the right population. I just wanted to throw this slide in. I think Dr. Alvarez had this slide as well, a variation of it, showing that the important part seen here is that this talks about progression of disability using the so-called EDSS scale, the expanded disability status scale. In here, starting about 3, where there's moderate disability, when you start to get into having gait disturbance, this is most of the patients have progressive MS here, and they're mostly in their 40s to early 50s. Unfortunately, with MS, perhaps changed somewhat by the disease-modifying therapies, once you get to here, it is very challenging. It seems to walk on here, affecting gait and other things, progresses, and none of the therapies have been particularly useful at slowing it once you reach here. So our big time to try and help people with the presently available medications is here. And so this is a recent paper from MS Base, which is a very large database, primarily in Europe. And this study, published last year, looks at progressive MS patients with activity, those who recently had an MRI scan change or a relapse, and then also people without activity. And the with activity is on the left, without activity is on the right, and they looked at either having a relapse, having accumulation of disability, or having patients who have reached that EDSS of 7, which we can see back here is restriction to a wheelchair. And without disease activity recently, in the last couple of years, either a relapse or a newer enlarging lesion on the scan in 1,000 patients, using a higher medication efficacy medication or a lower efficacy medication had no difference. The only difference that was seen was in those with recent activity on their scan or recent relapse with their progressive MS. And the only impact was on slightly slowing the likelihood of having a relapse, no impact on progression of disability, and no impact on reaching a wheelchair. So that, again, without disease activity that is recent, using a higher efficacy medicine, which may have more risk, didn't get you any more benefit, except for reducing relapses in a small percentage of those patients. So this all begs the question then, as people age, because this is when we're seeing the diminished impact of these medications, can we or should we discontinue disease-modifying therapies, or perhaps de-escalate and then discontinue? And it's all based on this concept that we have a huge population from which we have very little data supporting their use. And what data we do have, some subgroup analysis suggests the benefits are low. There are clearly greater benefits in younger patients. We know that recurrence, in observational studies, recurrence of new disease activity, should you go off, is clearly worse in younger patients with activity on their MRI scan or clinically. But there's little controlled data. There's observational studies, but no randomized controlled trials of stopping disease-modifying therapies. We also know that the cost of medications are unsustainably high. People often struggle to pay for these medications. In the study I'm going to show you in a second, the results of the DISCO study, I'll show a couple of slides. 8 people out of 128 people in the group that was maintained on medication within 22 months or 24 months lost their insurance. Now, this was partly due to the pandemic, but that was 6% of the population over less than 2 years stopped using medication because of insurance issues. But is it really safe to discontinue these drugs, the presently available ones, as people age? And there's a significant fear amongst people who have especially been stable for prolonged periods of time to potentially stop their medications. So this is a survey from NARCOMS that we did sort of on the side while we were doing the DISCO MS study, looking at people 56 on disease-modifying therapies. You can see how long they had MS, their first symptoms. They'd stayed on their medicine for a while. They're mostly on injectable or oral drugs. We asked a simple question. And that question was, would you be willing to consider a trial off your disease-modifying therapy? And you had 5 choices: very unlikely, unlikely, neutral, likely, or very likely. And the only 12% of people were likely or very likely, and 2/3 of people were unlikely or very unlikely to consider a trial off disease-modifying therapies. And that tells you, I think, that not surprisingly, people, especially if they have been stable, are concerned about the risk of recurrence of disease activity. So there's a great need to understand what those risks are. And that's why we did the DISCO MS study. There's also newer newer DMTs may come with higher risks, not always, especially routine and opportunistic infections. And you've actually seen some of this already, but with Dr. Schreiner. But the more highly effective therapies, they have risks that coincide with people as they age. For example, shingles is more common in several of the drugs that we use, but also as you get older, shingles is more common. So you have a confluence of both the MS and older age participating in risk, as well as the medications. And you saw the slide with Dr. Schreiner, and this shows, and this is again from the Swedes from a couple of years ago, even just with aging, your risk of having a significant infection, in this case, the line represents being free of serious infection, diminishes with age, and it's different by different drugs. And the highest risk is actually with rituximab. And we also know that, as Dr. Schreiner and I think Dr. Alvarez both noted, that disability is a major risk factor for that as well, not just aging and using the drug for a longer period of time, but if you're in a wheelchair compared to walking independently, and this again was with rituximab in a study with our colleagues at NYU, it's almost a 9-fold increased risk of having a serious infection if you're wheelchair bound. People who are wheelchair bound or bed bound have significant risks of infection related to skin problems, lung problems, or urinary tract problems. And there are potential benefits of discontinuation of disease-modifying therapies, as noted here. So what happens if we stop disease-modifying therapies? We know that if you're young, disease activity is likely to come back. However, if you're a little bit older, in this study, the average age is 54, people hadn't had a relapse for about 5 years, there was no increased risk of having a relapse or having a change in disability in people who stopped or stayed on their medication. But in all studies like this, all of these individuals stopped DMTs for many different reasons, not deliberately stopping it being due to disease stability at a certain age. So there are now 3 discontinuation studies. Ours is DiscoMS. I'll show you briefly that data, one in France and one in the Netherlands, looking at different populations to try to get randomized controlled data that will tell us what really happens when people stop medication. So here's from the DISCO data. Many of you may have seen this. The average age was 63. Average time since last relapse was about 14 years. People had been using many different medications, randomized to either stay on their medication, continue or discontinue. There was no difference between the groups at baseline. And the bottom line is when using either a relapse or a new scan change, we tried to show that it was not inferior if you went off medication, which is a different statistical question compared to saying something is better or worse than a different medication. And we were unable to show that because we had a combination measure of relapse and scan changes. And although there was only a single relapse in the continue group and only 3 in the discontinue group, which was no different between them, it was not inferior. When we threw the MRI scans on top, they're actually, we could not say that it was not inferior. It was certainly not inferior, but we couldn't say that it was not inferior. And what did we actually see? 15 of the 22 total events, 6 events here and 16 events in the discontinue group versus the 6 in the continue, 15 of the 22 total events was just simply having 1 or 2 new dots on your scan with no relapse and no change in disability. So the vast majority of what we saw was a small increased risk of having a new dot or 2 on your scan. We also saw no difference in progression of disability by group. We also showed that there was no relationship between having a little dot on your brain scan or a relapse and having progression of disability. So they seem to be independent events. And I'm going to skip over this, but I'll just tell you what it would mean. We know what having 1 or 2 new dots on your brain scan means, since that accounted for the vast majority of what we saw in this study. And the answer is no, not in this population. But in other populations, having just 1 or 2 new dots on your brain scan or no dots was associated with very low risk of having progression of disability over 12 years compared to people who had relapses or had new scan changes beyond that, 3 or more, or relapse, an enhancing lesion on the scan. With about any of those things would give you about a 6-fold increased risk compared to just having 1 or 2 new dots on your scan. But this is in a younger patient population who are being treated And it's not the same as with our population. So the real answer is beyond the 22 average months that people were in our study, beyond that, 5 years, 10 years later, we don't know because that data hasn't been generated yet. So the takeaways are from my discussion today is that the treatment principle should be to try to maximize the benefit risk ratio, which changes as MS changes and risk changes with the medications and benefits change with the medications with time. And the greatest benefits are seen in those who are younger with recent disease activity. But among older patients with no relapse or MRI activity, new activity is uncommon in our study, the DISCO MS study, and no different in DMT discontinuers. But there might be a slight increased risk of new disease activity as measured with little dots on your brain scan. And the significance of that is not known. So that DMT de-escalation prior to discontinuation is an option as well to be explored. And studies are being planned right now to actually formally do controlled trials looking at de-escalation. And consideration of DMT de-escalation or discontinuation eventually will still remain an individualized discussion with each individual. So there's not one size that fits all here. Everybody is quite unique. But I think it's fair to say that for many people who are relatively older and have not had new activity on their scan or with a relapse for a significant period of time, it is at least worth the discussion to potentially go off your medication. And I didn't show one slide here, but we asked people if they were in the DISCO study, if you were satisfied or not satisfied with your choice of medications in the study. And when they started, both the continue and discontinue groups were the same. At the end of the study, people who went off their medications were actually more satisfied. They were perfectly happy to not be on their medications. And that's because the vast majority of them did fine and they felt better and didn't have to worry about getting their labs checked and everything else that goes with that, not to mention the cost. So I think that's it for me. Thank you very much. We appreciate everybody coming. And I was almost on time. That's pretty good.